first wave of cases that we're going to talk about are transitioning from a removable prosthesis or prosthetics to fixed. And what do we do? What do we analyze? What do we do? What are the records? And then how do we go about it in surgery? So one of the very first things that we have to do when you're going from this to this is that we have to analyze a few things. First, we have to make sure we have enough prosthetic space, right? If you know the elementary things about full arch, you have to make sure that you have prosthetic space for fixed, right? So it's a pretty easy way to analyze it. You know, it's a ridge to ridge. I mean, you can do vestibule to vestibule for bite and all that, but ridge to ridge, bone to bone is a pretty simple thing to do, especially if a patient's already in a removable prosthesis. Do a dual scan, send it over, or you take a measurement. You can see, I'm going to talk about a few different things here, but one is how much bone reduction, how much display. You can see the necks of the teeth, and then the necks of the teeth in that red line, and then above it. All that is going to be displayed when you go to fixed, because that's where the tissue is, underneath it, right? I'm going to show you in a cross-section how we see that. And then, do we have enough vertical space, and what are we going to do about it? Right? Are we going to open the bite, or are we going to reduce bone, or a combination? You know, these cases, when you go fixed over fixed, you need at least 26 millimeters from implant to implant, because you subtract for tissue, and then you add for prosthetics, right? So today, yes, you can get away with doing a 10 millimeter prosthesis. We don't want to, but we will. So anything 10 or higher is going to be acceptable. Now, you got to keep in mind, though, that 10 millimeters of prosthesis is going to have a gummy smile, is going to have a display of a transition line, right? So that's not going to work. And you can see on that right image, that is from gum to gum in a cross-section of the dentures. An easy way to measure it. So there's your space that the patient currently has. The other images show the smile. And then, so that we make a determination, right? Are we going to have to reduce bone? Yes, we're going to have to reduce bone if you're going to go into fixed. That's a decision. And then the other is a cross-section from the profile to check out lip support, because many patients need a flange. And if you don't have a flange, then you have a ledge, or you stop providing lip support. Very important. All right, next patient. This is the smile is not quite as exposed, and you really want to be careful that the patient is giving you the full smile. And a little trick to that is, yes, you make them laugh. Yes, you tell them to smile as hard as they can, and then you have them close their eyes and do the biggest smile they can with their eyes closed. The muscles change. There's nice papers written on this to prove that a patient's lip will come up when their eyes are closed. All right, they may show you another 1, 2, 3, 4 millimeters. You never know, but you don't want any surprises. So here we are with another analysis, maybe a little bit of bone reduction. The inter-arch space, tissue to tissue, is only 17.3. So that has to be addressed. Either bone reduction or opening the bite. In this case, is going to be some bone reduction. Look at the flange. This is major decision time here. Bone is going to be elevated. You're going to lose a little bit of labial, not much. Patient has a lot of bone, but they don't have labial bone. And you're going to end up with a ledge. And you have to talk through it, because you can't make a flap, a ridge with a fixed prosthesis. Can't do it. So this is a discussion. Not all patients should go into fixed. Here's another, right? Same thing, 13 millimeters of space, and going to have to do augmentation, probably open the bite. You want to verify speech. You want to go through the whole protocols when you're going from removable to fixed. Flange is fine, no problem there, acceptable. And so those are the evaluations for denture-wearing patients, especially the maxilla, right? Go through those processes either with us or on your own and help determine it. So let's go through a case where a patient is in an patient's in removables, upper and lower, and the patient wants fixed restorations. All right, so this is Beatrice. We're going to tell her story. So when when this patient says yes, we're going to talk about the records. And the reason that we want to do guided surgery, doctor wants to do guided surgery, is multifold. One of them is we need to put these implants in specific strategic places where the bone is left, where the bone is remaining, usually very close to other implants, between implants. The real estate is quite limited, right? So we want to have a surgical guide that fits and puts those implants exactly where they're planned, as opposed to just exposing and putting implants in, right? Or randomly doing bone reduction, because we plan the whole thing from teeth down, right? So real estate is limited. And then you think when you're actually in the surgery, we have fixation pins, we have old implants, we have new implants, and we have to dial it in. Very, very precise. That's why guided surgery is such a wonderful thing. Now, what you're going to find is that the records are going to dictate the precision of the surgery. These are traditional dual scans. And what that means in traditional dual scans is, like we've always learned, is that the denture becomes the pin guide. All right. Now, this patient was all acrylic with some locator parts. All right. It still makes a little bit of scatter, especially obviously around those sites. But historically, we would have relied upon this to be the pin guide. And we would say, well, the pallet's going to hold it in place mostly, the ridge a little bit. Maybe you'll get a little bit of contact on those locators. But when you need this kind of precision, that's not good enough. And so this is one of our early cases, and we do debriefs after these surgeries. And we say, this situation where the pin guide is going to rotate. It is going to move, and everything is going to be a little bit off. And we can't have that. All right, so this is an early one. And when you generally, in these cases, you lay a labial flap first, you install the guide, you pin it, you hold it firmly in place, and you pin it. And as you can see from that pin guide, the way it was designed in the intaglio, that's going to be a bit of a struggle to make this thing fit perfectly, right? Yes, it goes down, but it's not a perfect intimate fit. Less than what we want. You can see the fixation base, which is our bone reduction guide. That metal is a fixation base, pretty close to what the plan is, right? But there might be a little bit more gap on the patient's right, a little bit more. So it's not in there perfectly. Now, the one nice thing is that our guide is very, very visual and open. So when you are in this situation, edentulous, it's usually off a little bit, right? You can't help it, it's soft tissue. You can see what you're doing. And you can make minor corrections on the fly. But that's not what we want. We want this to be perfect. And you'll hear me say a few times tonight, you want to leave a mount behind. And so what Dr. Castedo, and we've been preaching for a long time, is put an implant in that's easy in the anterior, 1, 2, 3 of them maybe. Secure the guide. Now your trajectory facially and your trajectory occlusally trajectories are stabilizing the rest of the metal so that you can put in your posterior implants, your pterygoids, everything is now really dialed in. Now, again, the guide has to be installed perfectly for this all to work. All right, so this case went from there to here all in one morning and did a lovely job. So most of these cases I'll have pre, post, and I always have pans, but some of them I won't have nice big smiling pictures at the end. And this is really more about the function, the purpose of what we're doing here as opposed to glamour shots. I have some glamour shots too. So here, this is another Adam. We're going to tell his story, and that is a second gen guide, pin guide. All right, that's the pinning guide is what installs the fixation base, our bone reduction guide. So again, this patient is in removable. You perform a dual scan. The patient came in with nothing. So we went through the normal general dentistry process, bite block, digital setup, try-ins like this. Maybe you do a wash impression with specific material, right, for dual scan, Kettenbach, Silginate, or green or blue mousse. Make sure those dentures are fitting perfectly for this scan. All right. There we go. And we did, of course, did our analysis of cross sections and labial support and all that. And once we get the dual scan here, then we are planning the implants, planning the fixation pins. We are, as you can see here, in a situation where we have limited real estate again. And we just have to nail how this pin guide goes in for the osteotomy guide and the fixation base. We have to nail it. And what you'll see here is we had the doctor do a 360 scan of the dentures, right? So it did a dual scan with the markers, but also did a 360 scan of the denture. And then we turned it into the pinning guide. So now we're a little bit more intimate fit on the locators, right? And these are locator abutments. We can do it on locator housings or straight right to the locator abutments, but this is a little bit better, starting to look better. All right, so this is as we're evolving with this case, because again, preferentially, we like to have the labial flap laid so you can pin the guide, the floating guide, and not have to come back and take the pins out and then lay a flap and then reinstall our bone reduction guide fixation base. We don't want to do it. We want to do this one time and move on. So in this case, because the pin guide fits better, lay the flap, put the pin guide in, hold it firmly, hold it very firmly. And I know maybe there's some minds out there thinking that maybe we could have the actual housings in the pin guide. It's possible, to pick them up, that kind of thing. But really, as long as the pin guide has a negative shape of those locators, we're going to be pretty darn close. Right? Nice installation. Implants are explanted. Patient had a lot of bone, so leave them out behind, put the implants in, go through the process. Right? So as long as this initial pin guide gets installed, the rest of it is going to be smooth sailing. I'm sure Savannah and team are going, yeah, sure. The only reason it's smooth sailing is because the doctor is so good at what he does. But he'll be the first one to put his hand up and say, I love this process. Even though he's so good at what he does, this makes it better. This enhances his approach to it because now he doesn't have to think all morning about aligning implants properly, about placing them perfectly between the implants that are being extracted, the bone leveling. It's all pre-planned. It's all completely pre-planned.